So good morning, everyone. Thank you, Dr. Chan, for that nice introduction. Good morning from San Francisco, and many thanks to the Arthritis Foundation for their support in funding this project, because without them and Kara, and of course all my mentors at UCSF, this would definitely not be possible. So I want to take just a few minutes to talk to you all a little bit about this project, which has a lengthy title, The Impact of Race via Cumulative and Intersectional Social Risk in JIA. So the background for this project is that, we have identified in the literature that race and social determinants of health definitely impact outcomes in JIA, but overall how they impact outcomes is poorly understood. We know, for example, that in Black youth and Native American youth, there are associations between their race and poorer outcomes, such as increased likelihood of joint damage, higher disease activity at disease onset and throughout the disease course, as well as functional disability. Other social determinants of health studies have been performed and have looked at other social risk factors such as poverty, such as adverse childhood experiences, and have demonstrated dissociations. But really the majority of existing JIA literature focuses on each of these social variables as independent risk factors in multivariate modeling. Whereas we know in reality that the world is more complicated than that, and it is very unlikely that these social risk factors work in isolation. So I'm going to show you an example in the next slide, but recent analyses have proposed that there may be a cumulative or additive effect and the presence of a social gradient with multiple social determinants of health and race impacting childhood arthritis. And so this award and project proposes the application of using the socioecological model, which I will explain a little bit further if you're not familiar, and statistical techniques to disentangle the interrelationships between race and racism and other social determinants of health on JIA outcomes. So just as a brief background, I want to highlight this work. This was a cross-sectional analysis of the National Survey of Children's Health from the years 2016 to 2019. If you're not familiar, the National Survey of Children's Health is a nationally representative survey that's given to better understand, the physical, emotional, and social health of children ages 0 to 17 all across the United States. It's administered through the US Census Bureau and HSRA every year. We had noted in the literature, both in adult diabetes and hypertension, the idea of creating a cumulative social disadvantage score and understanding if that may have impacts on poor health outcomes. And we decided to apply this technique in childhood arthritis using this data set. So you can see below in the chart here that we created a social risk score based off of social variables that were A, available in the data set, and B, have already been previously studied as independent risk factors in JIA. So for example, parental education level, if the subject reported high school education or less as from their guardian, that would give a score of 1. If their income level was between 0 and the 199th percentile of the federal poverty limit, that would yield a score of 1. Insurance status, a score of 1 if publicly insured or uninsured. And then this ACE refers to adverse childhood experiences, such as parental divorce, witnessing domestic violence, having a family member who's incarcerated, for example. Also would yield a score of 1 if they had a score of greater than or equal to 4. So this essentially, applied equal weight to every social risk factor, which, may not be the way things are in reality, right? But to get at whether or not there is the presence of a social gradient impacting JIA diagnoses. So we used univariate and multivariate logistic regression to understand how increases in the score might impact odds of a current arthritis diagnosis, as well as moderate to severe parental reported disease activity. And what we can see is that a score of 3 or 4 were statistically significant in multivariate adjusted models, adjusting for age, sex, and race and ethnicity in this study. But you can see sort of the additive or cumulative effect of successive exposure to social risk, making it having increased odds for an arthritis diagnosis, and a similar trend as far as moderate to severe disease activity. So I'm going to take a brief segue and talk a little bit more about the background of this project, and we're going to do a brief dive into some social science. If people haven't heard of the fundamental cause theory, this also informs this work. This was first described in 1995 by two social scientists named Link and Phelan. What they noted is that, despite significant advances in health over the 19th and 20th centuries, and more medical discoveries, that we still see the persistence of disparities in health, even though, if we were to think about it, right, everybody should be able to benefit from this new knowledge. And what they proposed is that socioeconomic status is a fundamental cause of poor health, because higher socioeconomic groups are more likely or more able to A, learn this information, and B, deploy resources to mitigate the effects of poor health. One example of this is the identification of smoking as a risk factor for lung cancer. Prior to the 1950s, when this was discovered, there was no social gradient in regards to those who had or did not have lung cancer. And since the 1950s, it's much more likely that if you are of a lower socioeconomic group, you're at higher risk for developing lung cancer, even though it should be noted across the general population, right, that risk of lung cancer. They amended their fundamental cause theory in 1995 to talk about the importance of race being A, predictive of socioeconomic status, and B, having an independent effect on causing poor health outcomes through racism. And so this really helps to inform this work. And I think, whether or not, I'm sure everybody in this audience is very interested in this kind of topic, right? This is a DEI summit. But even if you weren't, right, the implications of this is that if we, in our research and in our work, don't have any attention to DEI and the impacts of racism and socioeconomic status, we'll actually worsen disparities. So we all have to be aware of this. So we propose the application of the socioecological model to understand these relationships in our study. So this is just one example. This is from the Robert Wood Johnson Foundation. We see here at sort of the base of this rainbow, I guess we'll call it, as health, of course, right? And health is determined by, yes, in small part, maybe some interaction with genetic or other biologic factors, but there are these greater effects that affect sort of the base of the pyramid here, the base of the rainbow here. So including, behaviors and medical care, and individuals' living and working conditions, as well as economic and social opportunities and resources. And importantly, economic inequality and systemic racism can impact each level of this model as a fundamental cause for poor health. So that's how we can link the fundamental cause theory and the socioecological model together. An alternative way of looking at this is sort of like an onion. And this is how we're conceptualizing it for our study, right? So we know that there are many factors, that any individual experiences, right? So individual level factors, the context of their family, which is informed by their neighborhood and community, which is informed by greater society and other social factors. But importantly, things like racism can bleed through and impact every single layer of this model, right? And so ignoring this piece, we're never going to get to the ultimate goal of health equity and improving outcomes for all patients. So I'm just going to provide some examples of different factors that might be associated at each level, and highlighted in blue are ones that we can actually study and we're proposing to use in our models for this project. So for example, at the individual level, right, things like internalized racism, which is hard to directly measure, right? However, there are other factors that are measurable and available in our data set, such as insurance status. From the family level, we have access to the highest guardian education level and self-reported family income. from the neighborhood and community level. We're able to look at things like the urbanicity versus the rurality of the area that somebody lives in. We know for sure in pediatric rheumatology, given the dearth of pediatric rheumatologists and their concentration in urban areas, right, that might impact health outcomes, as well as social deprivation indices looking at the neighborhood level and how living in a certain neighborhood might differentially impact your access to health. And then, of course, there are these larger things that are a little bit harder to measure, right? But societal factors such as healthcare policies. And then, of course, even, like we said, racism impacts all of these different layers, but there are, sort of the bigger concepts, gerrymandering and mass incarceration and just historical context. These all can impact outcomes. So, this is a lot of big things, right? We can't measure all of them. So how do we, in some sense, try to simplify this into a model of the world in which we can study to better learn the interrelationships between these social risk factors? And that's really the aim of our project. So I'm going to talk about the three aims first. The first is analogous to that prior study that I showed you. So investigating the relationship between a cumulative social disadvantage score on disease activity as measured by the CJDAS, which is the Clinical Juvenile Arthritis Disease Activity Score. It's a composite measure including things like active joint count, as well as serum inflammatory markers and physician or patient global assessment of disease. And it's used as a common disease activity measure in the JIA literature, as well as functional disability. There's something called the Child Health Assessment Questionnaire for patients with JIA in the CARE registry. I know our prior speakers talked a little bit about the CARE registry, and I'll come back to it, but it is the largest data set that we have available in pediatric rheumatology, collating data of patients all across the United States and Canada to better understand diseases such as JIA. So in our project, we are creating a social score similar to what you saw in the prior study, though we don't have ACE data available through the CARE registry. And we're also interested in race as our primary predictor in this study. So we're going to use minoritized race, income level, insurance status, and guardian education level as the primary predictor in this first aim. In the second aim, we're going to get hopefully a little bit more granular detail to perform some of what we call intersectionality analyses, where we can understand the interrelationships between these social variables, right? Because we know it's probably not a linear relationship where race is equal to income is equal to insurance status, for example. So we are proposing using something called causal mediation analysis to perform essentially mediation analyses to understand and separate what would be the direct effect of a primary predictor in our project, that would be race, on our outcome, which just in this schematic, I just put disease activity, though we have a couple of outcomes, and how much of that is indirectly mediated through a mediator variable, which in our data set we're proposing using both individual and community level mediators, so that we can then understand what is the proportion of the impact of race, aka racism, that is mediated through these mediators, which may be hopefully more directly intervenable, such as guardian education as a proxy for health literacy, for example, versus what is the direct effect that's left over that are from factors that we can't measure and we would propose are likely due to some of those outer factors of our onion, right? Some of the things like societal factors of racism on patients and their outcomes that we can't directly measure easily. And our third aim is to investigate race and ethnicity and adverse JA outcomes, I guess more directly clinically interpretable outcomes, because not everybody understands like what a CJDAS score means. So there are a few adverse outcomes that are captured by the CARE registry, including joint damage, uveitis, which could be applicable to all JA subtypes. I should have said at the beginning of this talk that JIA is a heterogeneous group of diseases that are not all the same, as well as a few disease subtype specific outcomes such as macrophage activation syndrome and systemic onset JIA and active sacroiliitis and enthesitis related arthritis. Okay, this is a lot of text. This is just showing a little bit more of the details of our analysis. So our study sample, again, I mentioned, is the CARA registry from the Childhood Arthritis and Rheumatology Research Alliance. We're using data from JIA patients from December of 2015 all the way up to last month. Our inclusion criteria are that patients must have a primary diagnosis of JIA and will be excluded if race and ethnicity data is not available, as that is our primary predictor. And then if they have another secondary rheumatologic condition such as lupus. Our primary predictor, like I mentioned, with the exception of aim 1, where it's the score, but for the other aims will be self-identified race and ethnicity. And we already talked a little bit about our primary outcomes. I'll just put a plug in here that we're also going to look at promise measures to understand patient-reported outcomes as well. And covariates that we'll use for our multivariate modeling include things like age, sex, J category, distance and time to rheumatology care, possibly clinical site, and whether or not there's use of biologic medications sort of after their baseline visit. And our analytic approach, so again, in aim 1, multivariate regression, looking both at baseline and 12 months after diagnosis, and aim 2 will be more of the causal mediation analyses as we described. And then in aim 3, predicting whether or not somebody has one of these adverse JA outcomes, which lends itself more to a logistic regression analysis. We're still in discussion about this, but it's possible that we may use more of a repeated measures analysis to increase our power and be able to include more registry visits over the course of the cohort for the study. For those of you who are less familiar, these patients, they're enrolled at their baseline visit, which ideally is close to the time of diagnosis, but isn't always. And then there's registry visits every 6 months, and they're followed longitudinally over time. So our current status of our project, so we're still in very early phases, but we do have IRB approval. We have recently obtained our data from CARA. We've started some data cleaning, and we're hoping to have preliminary analysis results in the spring, probably more from aim 1, and the causal mediation analysis may take a little bit longer, but hoping to have more data to present to you all at CARA or likely ACR next fall. Thought I'd just show a few, very preliminary data, like we just got our data last week. So apologies that this is, broad strokes, but in total in our data set, we have about 10,000 patients with JIA. The distribution of subtypes is still data that we're working on in progress. We know that 70% of the cohort is female. This was interesting. So ADI, if you're not familiar, is something called Area Deprivation Index. It's a geo-coded social deprivation index that looks at somebody's neighborhood level and attempts to give a numeric value to how socially disadvantaged people are who live in that region based on a variety of factors such as income, access to education, neighborhood safety, hospital medical access, etc. And it's on a score of 0 to 100. The higher your score, the more socially disadvantaged you are. And at least in the cohort for the CARA cohort, the median ADI is 37 with an interquartile range of 25 to 60. And just to give some context to what that means, on average in the United States, the mean ADI is 41. And so it may be that our cohort is slightly more advantaged than the general population, but don't yet have data to fully conclude that yet, but one might wonder. As far as racial and ethnic background, our cohort is 80% white, 11% Latinx, 6% African American, and 3% other, or no answer. So, a predominantly white cohort. So again, I think the idea of using a repeated measures analysis to increase our power might be something we want to do, given that those of minoritized race are a smaller population of the care registry. Other demographic data, okay, this might be a little bit hard to read, but what we'll show here is that, about 30% of the cohort makes over $100,000 per year from what they report. But importantly, we don't know that data for about 13%, and about another 13% preferred not to answer, which is likely not random, right? So this is just to highlight why using some of those geocoded social deprivation indices may be really important to stay objective, and to not have bias introduced into the data or into our findings. 66% of the cohort was privately insured, and about 24% is publicly insured. And most guardians of patients in the care registry are relatively educated. So 43% with a college education and 24% with at least graduate school education. So very, very preliminary data there to just highlight some of the background of the demographics of our cohort and what we've discovered so far.